A pleasant day to everyone. This is Dr. Toom, and welcome back to the MedGuru CDB channel. Now, for this session, we will talk about the drugs that alter both sodium and water balance. In other words, we're going to talk about the diuretics. Now, this is a very high-yield session, which is lifted basically from one of the most high-yield pharmacology textbooks, which is your Katzum. Now, official reference for about 90% of this talk is your Katzum and Trevor's Pharmacology by Lang, 9th edition. Now, I would also take this time to give an acknowledgement to one of our most valued CDB alumni, Dr. Venil Lovely Balambao, for contributing to the preparation of this module. Now, Dr. Balambao is the top-notcher, first place in the last February 2015 Philippine Physician's Licensure Examination. So thank you, Dr. Lovely. Now, if we quickly go over this illustration, in a nutshell, there's actually just 4 major classes of diuretics that you have to memorize. However, if you want to score higher in the licensure examinations, you have to go to the textbook, and we will come to realize that there's actually more than 4 major classes. But let's start with the nutshell first. First, we have the carbonic anhydrase inhibitors. These will act on the proximal convoluted tubules of the nephron. Then we have the loop diuretics. From the name loop, they will act on the loop of Henle. Then we have the thiazide diuretics. They will act on the distal convoluted tubules. And lastly, we have the potassium-sparing diuretics, which will act on the collecting ducts. So please take a minute or so to go over this illustration. It is very difficult to proceed with the mechanism of action, the clinical indications, the drug toxicities, and the pharmacokinetics, unless you know where in the nephron these specific diuretics would exert its mechanism on. So let's recap. 4 major classes of diuretics. We have the carbonic anhydrase inhibitors, loop diuretics, thiazide diuretics, then we have the potassium diuretics. The carbonic anhydrase inhibitors will act on the proximal convoluted tubule. Loop diuretics will act on the loop of Henle. Thiazide diuretics will act on the distal convoluted tubules. Then we have the potassium-sparing diuretics, which will act on the collecting ducts. Now, this is a very busy illustration lifted from the 13th edition of Katzum. However, we have to go through this. So we have here basically the entire structure of the nephron. We have the glomerulus. We have the proximal convoluted tubules, the proximal straight tubules. So just remember the proximal tubules. We have the loop of Henle. This is the thin descending. This is the thick ascending. Then we have the distal convoluted tubules. And lastly, we have the collecting ducts. Now, if we zoom in here, acetylzolamide and your canagliflozin will act on the proximal convoluted tubules. So if you notice number 1, that's also number 1. So acetazolamide and your canagliflozin. Then we have the osmotic diuretics, which also acts here in the convoluted tubules. We have the loop agents, such as furosemide. which acts here. We have the thiazides, number 4, aldosterone antagonists. We have the anti-diuretic hormone antagonists here in the collecting ducts. And of course, we also have adenosine. Now, don't be confused. Don't worry. We're going to dissect everything. Now, first, some things we have to know regarding your proximal convoluted tubules. Now, always remember this magic number. 60 to 70% of the total reabsorption of sodium occurs in the proximal convoluted tubules. So the physiologic pearl, 60 to 70% of the total reabsorption of sodium you encounter in the proximal convoluted tubules. The proximal convoluted tubules is also the major site for the reabsorption of both sodium bicarbonate and sodium chloride, as well as other substances like amino acids, glucose, cations, and uric acid. Now, let's isolate the first group of drugs, the carbonic anhydrase inhibitors, wherein the drug acetazolamide is the prototype. Now, sites of action of your carbonic anhydrase inhibitors, as mentioned earlier, would be the proximal convoluted tubules. So do not take the examination unless you know the exact site of action. This can be asked in pharmacology, this can be asked in anatomy, this can be asked in physiology, and as well as therapeutics. So the site of action of carbonic anhydrase inhibitors is the proximal convoluted tubules, and as mechanism, it's going to inhibit the reabsorption of sodium bicarbonate. Now, examples, the prototype, memorize this by heart, acetazolamide. Other examples of your carbonic anhydrase inhibitors would be dorzolamide and bronzolamide. So if you only have one neuron left, memorize acetazolamide for your exams. Now, clinical uses of carbonic anhydrase inhibitors. So let's mention what's in the textbooks. Treatment of glaucoma, alkalization of urine, and for the treatment of altitude sickness. Now, I would strongly recommend you memorize the glaucoma and the altitude sickness. If you really ask me what I predict, it's going to be the altitude sickness that will come out in the exams. For example, you have a mountain climber who develops hypoxia at high altitudes. So one of the treatments of altitude sickness would be the giving of acetazolamide. Glaucoma, yes, this is used for the treatment of glaucoma, but if you're preparing for an exam, I would memorize pilocarpine for the treatment of glaucoma. Now, very busy table, don't worry. For all of those enrolled in CDB, you will get copies, a soft copy of the handouts here, and the corresponding passwords. So here, this is a table showing you the examples, complete examples of carbonic anhydrase inhibitors. Acetazolamide, we've mentioned dorzolamide, we have brinzolamide, methazolamide, and dichlorphenamide. So again, if you go to the textbook, so this is from the 13th edition of Katsung, you will notice there's always more drugs which are there. So if your goal is to get the highest grade possible and to top the exam, hit the textbooks while you can. So again, examples of carbonic anhydrase inhibitors. The prototype is acetazolamide. We have methazolamide, dichlorphenamide, dorzolamide, and brinzolamide. Now for the pharmacokinetics, carbonic anhydrase inhibitors in general are well absorbed after oral administration. And usually they will increase the urine pH within 30 minutes. So this is what we mentioned earlier. It's used for the alkalinization of urine. And please take note, the pharmacokinetics of carbonic anhydrase inhibitors, the dose is reduced in renal insufficiency. So this is the pharmacokinetics, or what the body does with the drugs. Now, what about the pharmacodynamics? Please take note. We have here sodium bicarbonate depletion, because carbonic anhydrase inhibitors will inhibit the reabsorption of sodium bicarbonate. So there's sodium bicarbonate depletion, which in turn will enhance the absorption of sodium chloride, leading to decreased diuretic effect after several days. So your carbonic anhydrase inhibitors are usually given short-term. Indications: memorize the glaucoma, but for the Philippine boards, don't forget the acute mountain sickness. So indications for alkalinization of the urine and metabolic alkalosis. And please take note, textbook also mentions in passing it's used in sleep apnea, epilepsy, hypokalemic periodic paralysis, patients with CSF leakage, and severe hyperphosphatemia. Doc, there's so many things to memorize. Focus on glaucoma, focus on the acute mountain sickness. Now, toxicity of acetazolamide leads to hyperchloremic metabolic acidosis. You have to memorize this. There's also the toxicity of renal stones, renal potassium, wasting, as well as drowsiness. And carbonic anhydrase inhibitors are contraindicated in patients with cirrhosis. Now, that was the complete table. Our goal in CDB is always to try our best to make every single warm-blooded soul inside our classrooms, whether on-site or virtual, to understand. So, let's slow down and let's summarize. Examples of carbonic anhydrase inhibitors: acetazolamide, metha, dichlor, and dorzolamide and brinzolamide. Special emphasis on acetazolamide. Well absorbed after PO administration, and dose reduction in renal insufficiency. Pharmacodynamics, as we mentioned earlier, depletion of sodium bicarbonate, which leads to enhanced sodium chloride absorption. And indications, emphasis on the glaucoma and the acute mountain sickness. So please remember, you have the liberty and convenience to review this video as many times as you want. And please do share it with your fellow pencil pushers and colleagues. So, as for the toxicity, special emphasis on the hyperchloremic metabolic acidosis. Now, the SGLT2 inhibitors, or the sodium glucose cotransporter 2 inhibitors. If you go by the textbook, this is classified under your diuretics and under your drugs that will alter your sodium and water balance. And present-day clinical use, we use it for diabetes mellitus. So again, sodium glucose cotransporter 2 inhibitors, or your SGLT2 inhibitors. Now, again, the complete table, then we'll dissect the table. So these are the examples of your SGLT2 inhibitors: DAPA, gliflozin, CANA, gliflozin, and your EMPA, gliflozin. DAPA, CANA, EMPA, gliflozin. So always remember, if you hear or encounter the suffix gliflozin or gliflozin, this is your SGLT2 inhibitors. Now, pharmacokinetics. These drugs are rapidly absorbed from the gastrointestinal tract. They are not recommended for patients who have severe renal and liver disease. And please take note of this very important drug interaction. Rifampin or rifampicin reduces the total exposure to dapagliflozin by at least 22%. So again, rifampin reduces total exposure to dapagliflozin by at least 22%. Now, clinical indication. Memorize this by heart. Treatment of diabetes mellitus. Causes significant decrease in your hemoglobin A1C. Now, other indications, weight loss and drop in systolic blood pressure. However, put all your focus on diabetes mellitus. Toxicity, hypoglycemia. It can cause genital fungal infections in women, and it's associated with increasing the chances of developing urinary tract infection. So, zooming in, I want everyone to remember this. These are your FDA-approved SGLT2 inhibitors, canagliflozin, dapagliflozin, and your empagliflozin. What we usually use for diabetes, your dapagliflozin, so that's your Farxiga. Now, let's mention the loop of Henle. So, reabsorption of sodium, about 1/4 or 25% of sodium reabsorption. Potassium and chloride reabsorption is through the NKCC2 carrier. Again, reabsorption of sodium, about 1/4. Reabsorption of potassium, chloride, is via the NKCC2 carrier. So you might be wondering what NKCC2 carrier is. That's your sodium, potassium, chloride 2 carrier. Now, the loop of Henle is also considered to be the major site of the reabsorption of both magnesium and calcium. And please take note that the thick ascending limb, so this area here, the thick ascending limb is impermeable to water. Now, major drugs that would act on the loop of Henle, we have the famous loop diuretics, wherein the prototype furosemide comes in. Now, here's the busy table. Loop diuretics, remember, this video is outlining and summarizing the tons of pages which are lifted from the textbook. So under the examples of loop diuretics, we have furosemide, bumetanide, torsemide, and ethacrynic acid. Now, I would advise for those with short-term memories to memorize by heart furosemide and ethacrynic acid. So, pharmacokinetics. Your loop diuretics will inhibit your sodium potassium chloride C2 channels. Most of these drugs are relatively short-acting, and the effects, take note, massive sodium chloride diuresis, causing the secretion of potassium at the collecting ducts. So these are potassium wasting. So your loop diuretics cause massive sodium chloride diuresis and at the same time causing potassium secretion. So please take note when you give loop diuretics to monitor your potassium levels. Blood pressure significantly decreases, and there's loss of your lumen positive potentials, as well as a reduction of the pulmonary vascular pressure. Now, clinical indications, I memorized this by heart. Treatment of edematous states, particularly congestive heart failure, ascites, and acute pulmonary edema. So repeat: heart failure, ascites, and acute pulmonary edema. Hypertension, we can also use loop diuretics for hypertension, but we usually don't use loop diuretics as first line for the treatment of hypertension. Clinical indications, in cases of severe hypercalcemia, loop diuretics can also be given. Now, toxicity causes electrolyte imbalance, hypokalemic, metabolic alkalosis, And this is what I want everyone to memorize for the boards: hypovolemia and autotoxicity. Now, please take note, furosemide is a sulfonamide, and it's notorious for causing sulfonamide allergies, particularly your rash. Do take time to repeat this video, master the contents. Now here, highlighting loop diuretics, memorize furosemide by heart, pharmacokinetics, inhibition of your NKCC2 channels, most important effect of loop diuretics, massive sodium chloride diuresis causing potassium secretion. Now, most important clinical indication of furosemide: edematous states, particularly congestive heart failure, treatment of severe hypercalcemia, and don't forget the most significant toxicity, examination-wise, would be autotoxicity and your hypovolemia. So if you know the style of Dr. Toom, focus on what is highlighted in red. You read through everything, first reading, second reading, emphasize on what's highlighted, third reading, second to third reading, that's already your mastery. And of course, hopefully, we pray you can crack your examinations and of course apply this to your own clinical practice. Now, I'm going to share with you this famous mnemonics on the net regarding your loop diuretics. So please remember this. ET is fabulous. So what is ET? E, ethacrenic acid. T, torsemide or torsemide. Fabulous, so fab, F-A-B, furosemide, azosemide, and bumetanide. Now, clinical uses of your loop diuretics, just remember HE. So HE, heart failure, hypertension, edema. Side effects, memorize the mnemonics: hypo with a big letter O. So it's hypo, so we have hyponatremia, hypokalemia, hypomagnesemia, and autotoxicity. So hypo, hyponatremia, hypokalemia, hypomagnesemia, and the big letter O is autotoxicity. So if your patient presents with autotoxicity, first two drugs you should ask in your medication history would be aminoglycosides. Next would be your loop diuretics. Now, let's zoom in to the distal convoluted tubules. So here, this is where your distal convoluted tubules is. Now, always remember, only 10% of sodium chloride is reabsorbed via the NCC, or the sodium chloride cotransporter. Now, this is your NCC. See this? So what does NCC mean? Sodium chloride cotransporter. Only 10% of sodium chloride is reabsorbed via the NCC. And please take note, the distal convoluted tubule is impermeable to water. And this is where you would encounter the reabsorption of calcium, which of course is regulated by the hormone parathyroid hormone. Now, prototype thiazide would be your prototype thiazide diuretic would be your hydrochlorothiazide. Hydrochlorothiazide can be given as a sole drug or in combination with other antihypertensives. Now, summed up table, we have the examples. Prototype is hydrochlorothiazide. We have chlorothiazide, chlorthalidone. Now, those with short-term memories preparing for an exam, just memorize hydrochlorothiazide. And don't forget, it is chlorothiazide, which is intravenous. Now, pharmacokinetics, memorize inhibition of the sodium chloride co-transporter 2 channel in the early distal convoluted tubules. Duration of action is estimated to be 6 to 12 hours. It's very active via oral route. That's why it's usually given as tablets. And don't forget, thiazide diuretics will exert a synergistic effect with your loop diuretics. So be careful if you give them together. Now the effects are moderate, but they're sustained sodium chloride diuresis. Other effects of thiazide diuretics, this is actually what I want you to memorize, increases calcium reabsorption. It can also lead to dilutional hyponatremia, and as an antihypertensive, it reduces the blood pressure. Main clinical indication of thiazide diuretics would be hypertension, chronic therapy of edematous states. Don't forget acute edematous states, congestive heart failure, acute pulmonary edema. Best drug to give would be your loop diuretics. Thiazides can also be given for the treatment of chronic renal calcium stone formers. And don't forget, although it's not highlighted, this is actually what I expect in the Philippine licensure examination: nephrogenic diabetes insipidus. So treatment of nephrogenic diabetes insipidus. Now, toxicity, there's massive sodium diuresis, hypokalemic metabolic alkalosis, hyperglycemia, hyperuricemia, hyperlipidemia. And don't forget, it's also associated with your sulfonamide allergies. And be cautious about the hypotension when combining thiazides with your loop diuretics. So, for mastery purposes, review purposes, so I just enlarged the slides for better viewing purposes. So thiazides, memorize the prototype hydrochlorothiazide. Most important pharmacokinetic principle you should memorize to crack the boards is the inhibition of your NCC2 channels. So what is your sodium potassium chloride co-transporter, or your NKCC? This is a protein that aids in the secondary active transport of number 1, sodium, number 2, your potassium, number 3, chloride. So a protein that aids in the secondary active transport of sodium, potassium, and chloride into the cells. Now, effects: moderate but sustained sodium chloride diuresis, and the ones I want you to memorize and bring to the boards: increased calcium reabsorption. And don't forget the dilutional hyponatremia. Clinical indication: we have hypertension, treatment of chronic renal calcium stone formers, and please insert the treatment of nephrogenic diabetes insipidus. Now, I just like to mention this. There's a drug called lithium. So lithium is usually used to treat bipolar disorder. When a patient is on lithium, you have to be careful because one of the side effects of lithium is actually nephrogenic diabetes insipidus. So ending with the thiazides, memorize the hypokalemic metabolic alkalosis, hyperglycemia, hyperuricemia, and hyperlipidemia. Now, let's proceed to the collecting tubules and the ducts. This is actually the final site for the reabsorption of sodium chloride. So we have here the collecting tubules. This is also the site for aldosterone. This is also the site for potassium secretion and urinary acidification. Now, memorize anatomy, physiology, therapeutics. Where is the site for aldosterone, potassium secretion, and final sodium chloride reabsorption? It's the collecting tubules. Now, take note of these cells. We have the principal cells, and we have the intercalated cells. The principal cells would be responsible for the transport of sodium, potassium, as well as water. The intercalated cells is for the secretion of hydrogen and bicarbonate. Now, tip, what you see here in the illustration is the intercalated cells down here. Although it's not mentioned here, you have the alpha intercalated cells. This is for the secretion of hydrogen. Then you have the beta intercalated cells. This is for the secretion of bicarbonate. Now, the collecting tubules is also the site of final urine concentration. So final urine concentration occurs in the collecting tubules and ducts. And this is also where you would encounter your ADH, or your antidiuretic hormone, or your vasopressin. Now, don't forget, your biochemistry and surgery textbooks would call it arginine vasopressin, or your AVP. So, what is the significance of your antidiuretic hormone, or your vasopressin? Now, I want everyone to zoom in here. AQP2. What is this AQP2? This is the abbreviation for your aquaporin 2. So aquaporin 2, as the word aqua indicates, is water. Okay, so antidiuretic hormone, or vasopressin, would regulate the insertion of these preformed water channels, which we call AQPT, P2, or your aquaporin 2, into the apical membrane. So let me repeat that. One of the important actions of antidiuretic hormone is to regulate the insertion of your preformed water channels, or your aquaporin 2, into the apical membrane. So memorize this physiologic pearl. If there is no antidiuretic hormone, that means the tubules will be impermeable to water. Therefore, what will be produced is dilute urine. Now, antidiuretic hormone also stimulates the insertion of urea transporters into the apical membrane. So, let's mention the potassium-sparing diuretics, wherein the prototype is your spironolactone. Now, prototype example of potassium-sparing diuretics is spironolactone. Other examples of potassium-sparing diuretics, we have eplerenone, triamterene, and amiloride. Doc, I have the worst memory in the world. I'm preparing for my exam. What should I memorize most? Spironolactone. Okay, so other potassium-sparing diuretics: eplerenone, triamterene, amiloride. Now, let me highlight spironolactone. Mechanism of action, memorize this by heart. Aldosterone receptor antagonists. That's going to come out in exams. So your spironolactone is a competitive aldosterone receptor antagonist. Your triamterene and amiloride will block your sodium channels. I hope everyone's still with me. So I hope you take time to review this video. It's going to be much faster and more high yield than reading the textbooks. Now here's the busy slide. Examples of potassium-sparing diuretics. Pharmacokinetics. I want everyone to memorize what I highlighted in red. Triamterene and amiloride will block your epithelial sodium channels, or your ENaC. Spironolactone and eplerenone will block the intracellular aldosterone receptors. So always remember, the aldosterone receptor is only blocked by spironolactone and eplerenone. Triamterene and amiloride don't act on the aldosterone receptor. The effects increase in the sodium clearance, decrease potassium as well as hydrogen excretion. Clinical indication for potassium-sparing diuretics. Number 1 would be heart failure. I would like to put this on top. Then we have hyperaldosteronism. Toxicity causes hyperkalemic metabolic alkalosis. My prediction, sorry for the typo there, is they're going to ask you spironolactone causing gynecomastia. Now, please be careful. When you give potassium-sparing diuretics, do not give them with potassium supplements, ACE inhibitors, or ARBs, particularly potassium supplements, or else you're going to end up having a hyperkalemic crisis. So zooming in, memorize spironolactone, memorize the blockage of ENaC, and spironolactone being a competitive aldosterone receptor antagonist. So what is ENaC? Or your epithelial sodium channels. This is located on the apical membrane of your epithelial cells of your distal renal tubules. So ENaC stands for epithelial sodium channels. Now question, does aldosterone act on your ENaC? No, it doesn't. It acts on your aldosterone receptors. Now, what about your potassium-sparing diuretics? Now, please take note that main indication I want you to memorize is heart failure. Okay, so please memorize heart failure. Now, as for toxicity, please don't forget, I want everyone to memorize the gynecomastia. Okay, so please memorize the gynecomastia. Now, let's proceed. I want everyone to memorize this by heart. So this is what you expect to be asked in any standard exam. What are the drugs that can cause gynecomastia? So we have spironolactone, cimetidine, and ketoconazole. So again, the million-dollar question, what are the drugs that has the side effect of gynecomastia? Spironolactone, cimetidine, and ketoconazole. So please memorize that. Now, we're almost done. Antidiuretic hormone agonists and antagonists, wherein I would like everyone to memorize vasopressin. So here's the busy table. So always remember this. The antidiuretic agonists, of course, is ADH. Then we have desmopressin. Put all your effort in memorizing desmopressin. The antagonists, we have conivaptan, tolvaptan, demiclocycline, and lithium. So again, examples of your agonists, desmopressin, antagonists, conivaptan, which is intravenous, tolvaptan, demiclocycline, and lithium. So mechanism of action of your desmopressin, it activates your vasopressin 2 receptors, causing insertion of your aquaporin channels. Effect, decrease in the urine volume, increase in the urine concentration. Major indication is for the treatment of neurogenic diabetes insipidus. Now, I'd like to highlight, earlier we mentioned nephrogenic diabetes insipidus. So in diabetes insipidus, if it's nephrogenic, the problem is the receptors in the kidneys, the antidiuretic hormone receptors in the kidneys. If we say neurogenic diabetes insipidus, This is usually caused by problems of the posterior pituitary gland or, for example, brain tumors. So toxicity of your desmopressin is dangerous delusional hyponatremia. Now, antagonists, tolvaptan, this is a selective vasopressin 2 blocker. It does the opposite of desmopressin. It increases urine volume, decreases urine concentration. Treatment for SIADH or syndrome of inappropriate antidiuretic hormone. And please be careful of the toxicity. This can cause demyelination if your hyponatremia is corrected too rapidly. So you're going to end up with osmotic demyelination syndrome, osmotic demyelination syndrome, or what we previously called as your central pontine myelinosis. Central pontine myelinosis. So let's dissect. Desmopressin activates V2 receptors. The antagonist blocks the V2 receptors. Take note of the effects. Opposite effects of the agonists: decreasing urine volume, antagonists increasing the urine volume. Treatment for diabetes insipidus, neurogenic. This is for the agonist, ADH agonist. For the ADH antagonist, treatment of your SIADH. Now, take note. Demiclocycline, having a tetracycline structure, is notorious for causing bone and teeth abnormalities. So always remember, tetracycline is bad for your bones, it's bad for your cartilage, it can also cause teeth discoloration. Now lastly, we're finally here, your osmotic diuretics with the prototype mannitol. Now, this is the busy table, so let me go straight to the summary. Examples of osmotic diuretics: mannitol, memorize this by heart. Medical interns would have their experience giving mannitol for their neurosurgical patients, those big syringes. So we have glycerine, urea, and isosorbide. Memorize the mannitol. Pharmacokinetics. Your osmotic diuretics are freely filtered in the glomerulus. However, they are poorly reabsorbed from the tubules, and they cause an osmotic effect. So they're going to cause osmotic diuresis. Major location, memorize this by heart, of your osmotic diuretics like mannitol is the proximal convoluted tubules. Effects: increase in urine volume, increase in excretion of solutes, and of course, decrease in the brain volume, decrease in the intracranial pressure, and to some extent, decrease in the intraocular pressure. Now, rule of thumb, if you want to decrease the intraocular pressure, you give the acetazolamide instead, especially for glaucoma. If you want to decrease the intracranial pressure, the most widely used drug to decrease the intracranial pressure is your osmotic diuretic, mannitol. So please take note of this. So what should we watch out for with mannitol? Take note. 1 is decrease in your blood pressure. It can cause hypotension. That's why when we give mannitol, there's always a blood pressure precaution. So in a nutshell, memorize mannitol as your prototype osmotic diuretic. Memorize the major location of action, which is the proximal convoluted tubule. And lastly, memorize the decrease in the intracranial pressure. So with this, I have outlined the must-knows about your diuretics, the drugs that affect water and sodium balance. So memorize that by heart. And we're going to end up with this pearl. Clinical indications for osmotic diuretics: to maintain high urine flow, especially in patients with severe hemolysis, rhabdomyolysis, or tumor lysis syndrome. Even though the book says acute glaucoma, again, memorize acetazolamide for the glaucoma. This is the major indication for osmotic diuretics in our present-day practice, to decrease the intracranial pressure in neurologic conditions. Example, stroke, hemorrhages. But I would like to inform everyone, this is not yet part of our talk, but if you do have vasogenic edema in the brain, to decrease the vasogenic edema, especially in brain tumors, then steroids like dexamethasone would be superior. Toxicity: osmotic diuretics can cause hypernatremia. It can also cause hypovolemia. And be cautious in giving mannitol in patients with heart failure, because this can actually trigger pulmonary edema. And of course, headache, nausea, and vomiting. Focus on what's highlighted in red. Take time to review all of the slides. You can repeat it as many times as you want. Hopefully you can share it with your friends. Focus on what's highlighted in red. So with this, I hope you learned something, and I hope I've showed you that with the right guide and mentor, you can actually summarize the loads of pages from the mother textbook and still learn in a well-paced manner. So this is Dr. Toom, your med guru of cracking the boards, saying thank you, happy studying, and God bless. Salamat.